I'm going to be reviewing neonatal complications, and I would like us to start with cleft lip and palate. Okay, so with cleft lip and palate, this is a common congenital malformation. And when you assess your clients, especially the one with a cleft lip, you're going to see a small or maybe a large fissure in the facial processes of the upper lip, or even up to the nasal septum. It could also include the anterior maxilla. Whereas with a client with a cleft palate, you will notice this fissure. It could be midline, it could be bilateral or unilateral. They have in the hard and soft palate. So that's what your cleft lip and cleft palate looks like. So again, for cleft lip, it's usually repaired during the first 1 to 3 months of age. And a cleft palate is usually repaired before the child develops altered speech patterns, so maybe between 12 to 18 months. And with our plan for these clients, remember the parents will have a strong reaction to the birth of their child who is defective. So we want to provide support and provide necessary information. We want to assess the infant's ability to suck. We'll need to carry out a surgical repair during the preoperative period. We want to maintain adequate nutrition. Remember where you have these fissures. So we might want to feed the infant with a soft nipple or a special lamb's nipple or a breeched feeder or a cup. And remember to feed slowly and to burp the child often because they'll be taking in a lot of air. In the post-operative period, we want to try to maintain the airway. We'll be observing frequently for any signs of respiratory distress or signs of aspiration or blockage from maybe edema from the surgical process. We need to keep checking the client's ability to swallow. We would also need to provide suction equipment and even our endotracheal tube at the bedside, just in case of any eventuality. We'll need to guard the suture line. So you want to keep the suture line clean and dry. We want to use lip protective devices like your Logan bow or tape. So this is an example of what your Logan bow looks like. We'll need to maintain the infant in a side-lying position on the unaffected side. We'll need to clean the suture line with cotton tip swab dipped in saline. And then we can now apply maybe a thin coat of antibiotic ointment. So again, we'll be using just regular saline to clean the suture line. We want to minimize crying. So you want to use those comfort measures like rocking the child or cuddling the child. We'll need to place an elbow restraint just to stop any movements towards where we have done the repair. We'll also need to provide nutrition. So we'll use feeding techniques to minimize trauma. So you want to feed the infant. Remember, they're usually very slow to feed. And like we said previously, you want to burp the baby frequently during feedings. We would also need to facilitate the parents' positive response to the child. Remember, we said they will have this reaction to their defective child. So that's part of our job to help facilitate that bonding. And we would also need to provide referrals to a speech therapist or an orthodontist as needed. Another neonatal complication we'll need to review would be neonatal sepsis. Again, some predisposing factors to an infant becoming septic in the neonatal period would be prematurity, maybe maternal signs and even symptoms of infection, like a beta hemolytic streptococcal vaginosis. Even invasive procedures and maybe during resuscitations, these also predispose to neonatal sepsis. Rupture of membrane, whether premature or prolonged, would also be a predisposing factor. Prolonged labor or delivery by cesarean section or even forceps delivery would also be a predisposing factor. And again, aspiration of meconium fluid can also lead to neonatal sepsis. When we assess our client, what are we going to see? They're going to have this they are usually hypothermic. Remember, that's one sign of sepsis in an infant. Most times they are not febrile, rather they will have this temperature instability and they're usually hypothermic. There will also be poor sucking, vomiting, diarrhea, feeding intolerances. You would see lethargy. They will have this convulsive activity. You could also notice episodes of apnea. There will be lack of weight gain, dehydration. Those are what we'll see when we assess this client. And what is our plan for this client? We'll need to administer prophylactic antibiotics for at least 7 to 10 days. Because of those apnea and issues with breathing, we'll need to place them on oxygen. Because of that poor feeding we talked about, we'll need to temporarily discontinue oral feedings, and we might need to transfuse them with fresh irradiated granulocytes or polymorphonuclear leukocytes. Remember, granulocytes are irradiated to prevent those transmission-associated graft versus host disease. So that's why we most times irradiate some of our granulocytes. So that's our plan for this client. We would also need to give them immune therapy or our gamma globulin. This is used to treat immune deficiency conditions that can make the client susceptible to infection. So we'll need to place them on gamma globulin. With cold stress, remember the infant is unable to increase activity. They lack that shivering response to cold. Remember, heat is produced through metabolic processes in the body. These infants lack that shivering response to cold. And as a result, oxygen consumption and even energy is diverted from maintaining the normal body processes to generating heat in the infant or to thermogenesis. So that's what we see with cold stress. So again, if the infant is exposed to cold, there will be increased oxygen consumption, there will be increased respiratory rates. This in itself could lead to peripheral vasoconstriction, and then you're going to see a decrease in PO2 and the pH level, and that's going to cause the client or the child to go into metabolic acidosis. You would also see an increase in the breakdown of glucose. So again, those are some of the highlights of what happens with cold stress. So when we assess a client in cold stress, you would notice there will be cyanosis or there will be mottling of the skin. Like we said, it's going to be metabolic acidosis as the PO2 decreases and the pH decreases. The client is going to go into metabolic acidosis. So you're going to see those abnormal blood gases. There will be hypoxia, which we said the PO2 is going to go down. Again, there will be a hypoglycemia. Remember, we said there will be an increase of breakdown of glucose. So the glucose level is going to drop. So you're going to have hypoglycemia in this infant. And what's our plan for this client? Is having cold stress. So you want to place him in a heated environment immediately after birth. We want to dry the infant immediately. We want to monitor the child's temperature. We would also need to maintain a neutral thermal environment. You know, you can put him in a double-walled incubator or a servo-controlled incubator. We would need to use radiant warming panels. We can use an open bassinet with cotton blankets, and we also want to cover the infant's head. And we will need to place the infant on the mother's abdomen. We can also use fabric insulated cap for the infant's head just to help to keep him warm. With NAS, or neonatal abstinence syndrome, or narcotic addicted infants, this is also another neonatal complications that can arise. NAS is actually a group of conditions that is caused when a baby withdraws from drugs he has been exposed to when he was in the womb. So when a woman takes opioids during pregnancy and then the baby is delivered, that withdrawal from the opioid is going to result to the client being narcotic addicted, or you're going to see this neonatal abstinence syndrome. So with our assessment in a client with NAS, what are you going to see? They will have this high-pitched cry. They will have this hyper-irritability or hyper-reflexivity. There will be decreased sleep. The client will be excessively sweating. Their breathing will be higher than 60, or what we refer to as tachypnea. They would also be restless. Remember, we said they have this hyper-irritability. You would also see tremors, uncoordinated sucking, frequent sneezing and yawning. You will see this non-nutritive sucking. There will be sucking, but like we said, it's uncoordinated. And drug withdrawal from maybe narcotics or barbiturates or cocaine, they manifest as early as 12 to 24 hours after birth. They can even manifest up to 7 to 10 days after delivery. Again, the Nclex is going to tell you a mother who's been living on the streets has just delivered, and maybe 24 hours after birth, the baby was initially fine, and then 24 hours or 12 hours after birth, we start noticing this high-pitched cry, excessive sweating, tremors, frequent sneezing and yawning. So you want to start thinking about neonatal abstinence syndrome. How can we help this client? We want to assess their muscle tone. Remember, we said they could have that hyperreflexivity. So we want to assess for irritability. We want to assess their vital signs. We'll need to administer phenobarbital, chlorpromazine, your diazepam, your methadone. Remember, these are non-morphine treatments, and they provide symptomatic relief for the child. We would also need to report symptoms of respiratory distress. We'll need to reduce environmental stimulation. For example, you want to dim the lights in the room. You want to decrease noise levels. We'll also need to provide adequate nutrition and fluids. We'll need to provide a pacifier for that non-nutritive sucking. We'll also need to monitor the mother and the child and how they interact. We'll need to wrap the infant snugly. You want to hold them tightly. This is also going to help to facilitate that parental attachment. So you want to teach the parents to wrap them snugly, rock them, hold them tightly, just to facilitate that parental attachment. Again, that's how we want to manage our clients with NAS. And with hypoglycemia or neonatal hypoglycemia, this is a very common metabolic problem in newborns, and it's actually defined as a plasma glucose level of less than 30 milligram per DL, especially in the first 24 hours of life, and less than 45 milligram per DL thereafter. So again, the neonatal period, in the first 24 hours of life, we don't want the blood sugar of the infant going less than 30 milligram per DL. So again, when you assess this client, what are the common symptoms you would see? For example, we'll see poor feeding or vomiting, respiratory problems. For example, the client may be apneic. There would be hypothermia. You would notice jitteriness, grunting, or irritability. So that jitteriness, whenever I see it in a child, I'm already thinking hypoglycemia. There could be bluish or pale skin color. The client could be lethargic, and you would also see tremors or seizures in this client. How can we help this infant? What do we need to know about hypothermia, the neonates for the Nclex? So again, we need to monitor glucose levels after birth. And again, we need to repeat in 4 hours. We want to make sure it's not less than 30 milligram per DL. And again, we'll need to administer glucose carefully to avoid rebound hypoglycemia. So again, if it's low, we'll need to administer glucose. And if we do, we'll need to administer it carefully to avoid rebound hypoglycemia. And we'll need to initiate feedings if the infant is not lethargic. So again, we can initiate feedings if the infant is not lethargic. And while we do this, we'll reassess glucose levels immediately before each feeding. So again, that client is at risk for stable blood glucose. So we need to make sure that the client's glucose level is returned to normal. With respiratory distress syndrome, it's another common lung disease in premature infants, and it occurs because the baby's lungs are not fully developed. So you will see RODS caused by prematurity, or maybe the baby not having enough surfactant in the lungs. Remember, surfactant is that liquid that is made in the lungs at about 26 weeks of pregnancy. And as the fetus grows, the lungs make more surfactant. And surfactant actually coats the tiny air sacs, and it helps to keep them from collapsing. So in a client with respiratory distress syndrome, what are we going to see? He's going to have labored respirations after several minutes or hours of normal respiration initially. So usually they present in an acute state. So you're going to see all of a sudden the client has normal respirations, or he's been breathing fine, and all of a sudden you notice this labored respiration. And if we assess the client further, you're going to see him becoming cyanotic. You would hear this expiratory grunting. You look at the face, you will notice there's nasal flaring. He's using his intercostal and subcostal muscles, so you see those intercostal retractions. And again, the breathing will be more than 60 breaths per minute. It could also progress further to unresponsiveness and even apneic episodes. Again, what's going to be our plan for this client? We can carry out some diagnostic tests. A very important one you will need to know would be amniocentesis, where we look at the lecithin sphingomyelin ratio. This test measures or looks at the fetal amniotic fluid to assess for fetal lung maturity or immaturity. So we can carry out the LS ratio or the lecithin sphingomyelin ratio. Again, we are trying to assess for fetal lung immaturity. And part of our plan would be to maintain body temperature for this client. We want to maintain a neutral thermal environment. We can give parenteral nutrition during the acute phase. So nipple feeding will be contraindicated in this period. Gavage feeding will be contraindicated. So we'll need to give parenteral nutrition during the acute phase. We'll need to maintain hydration with IV fluids and maintain a patent airway. Again, we'll need to suction as needed. Part of keeping the airway or maintaining the airway positioning is very important. So we want to place him side lying with the head supported by a small folded blanket or on his back with the neck slightly extended. We may need to incorporate PEEP or CPAP. So again, you want to keep, if we're using a nasal prong, we want to keep them in place. We want to carry out high frequency ventilation. Remember, PEEP is used to improve oxygenation and prevent the alveoli from collapsing, especially in mechanically ventilated patients who have this acute respiratory distress syndrome. So your PEEP is designed to keep the alveoli open during that breathing out phase or the expiratory phase. Whereas CPAP is used to treat preterm infants whose lungs are not fully developed. So that's where we bring in our CPAP. CPAP means continuous positive airway pressure. PEEP means positive end expiratory pressure. So your CPAP machine uses mild air pressure to keep the breathing airways open while the patient is sleeping. So they actually use it to treat sleep-related breathing disorders like your sleep apnea. So that's where we're going to use our PEEP or our CPAP. We can also place the infant in an oxygen hood, or we carry out mechanical ventilations. We will also need to start him on antibiotics, diuretics, or vitamin E, or even surfactant therapy. And the last we'll look at would be our perinatal asphyxia. This is another neonatal complication, and it's a medical condition resulting from where oxygen is deprived to the newborn infant during the birth process, and it leads to harm, usually to the brain. So again, what are predisposing factors? Again, if the child is small for gestational age, or maybe if the mother has a history of heavy cigarette smoking, that could also predispose the client to perinatal asphyxia. Preeclampsia or eclampsia, multiple gestations, these are also predisposing conditions. When you assess this client, we're going to see meconium staining, especially in a non-breech delivery. So that's a red flag there. So there will be meconium staining. There will be signs of intracranial damage, increased pressure. The fontanelles will be altered. You will see seizures The heart rate is going to be slow, so you will see bradycardia. There will be poor muscle tone. Their reflexes will be weak. You would also notice abnormal respirations with cyanosis and decreased respiratory rates in these infants. And what's our plan for them? Again, we need to prepare for aggressive ventilatory assistance because they have that impaired gas exchange, they have that ineffective tissue perfusion. So we need to prepare for that aggressive ventilatory assistance. And again, we would strive to keep the airway open. With hyperbilirubinemia, this is a condition in which there is a buildup of bilirubin in the blood, and that is going to cause the sclera of the eyes, even the skin, to become yellowish, which is what we call jaundice. So we can have this condition present as a physiological jaundice. Usually this physiological jaundice is caused by immature hepatic function. So the liver is immature, and as a result, the functions are affected. It could also be caused by a resolving cephal hematoma. So again, with this cephal hematoma, if an infant has a cephal hematoma, it can actually lead to increased bilirubin in the blood because there's going to be breakdown of that extravasated blood that's causing that that makes up the hematoma. So as that extravasated blood is broken down, more bilirubin is drawn into the blood system. So again, that's how your resolving cephal hematoma can even lead to physiologic jaundice. Again, this jaundice is seen after 24 hours and it peaks at 72 hours and it can last 5 to 7 days. Again, for your physiologic jaundice, no treatment may be required. We could also have breastfeeding jaundice. This has early onset and is caused by poor milk intake. The onset is usually between 2 to 3 days and it could peak at 72 hours and is treated by frequent breastfeeding and giving of caloric supplements. We could also have a late onset breast milk jaundice, which is caused by a factor in the breast milk. Onset is between 4 to 5 days. It could peak 10 to 15 days and is treated by discontinuing breastfeeding for at least 24 hours. And with pathologic jaundice or your hemolytic anemia, this is caused by blood antigen incompatibility. Again, the onset first 24 hours. The peak is variable and is treated by phototherapy or can even carry out exchange blood transfusion. So what's our plan for a client with hyperbilirubinemia? We want to assess serum bilirubin levels. At them, it should be 2 to 5 days, it should be less than 12 milligram per DL. So at them, within the 2 to 5 days, it should be less than 12 milligram per DL. So we also want to observe the depth and extent of jaundice in this client. We want to observe the infant's behavior. We might need to carry out phototherapy. We might need to increase fluid intake, observe for adverse effects. Remember, when we're carrying out phototherapy, we want to patch the eyes. And again, we want to uncover them every 2 hours. So when you patch the eyes, make sure that every 2 hours you open the eyes just to ensure that there's that stimulation. Again, you want to expose the skin as much as possible, but please cover the genitalia. We want to provide sensory stimulation. We also want to provide opportunities for bonding, and we will need to carry out exchange blood transfusion to remove excess bilirubin. So again, remember with this client, there's that risk for injury due to CNS involvement. There's that risk for injury, maybe as effects of treatment. So again, we need to make sure that these complications have been prevented and bonding between the parents have taken place.